Complaints of abdominal pain for 1 month, an increase in intensity for 1 day, abdominal distension for the past 1 month, and leg swelling for 1 week. She was diagnosed with a case of acute Budd-Chiari syndrome elsewhere and underwent thrombolysis of the right hepatic vein, followed by stenting of the right and middle hepatic veins just 2 weeks before presentation, and was started on heparin and warfarin post-intervention in the previous hospital. She also had a hemoperitoneum during the hospital stay in the previous hospital and underwent glue embolization of the right atrial mammary artery for the same. On clinical examinations, we could visualize the abdominal distension and the bilateral volume swelling. And on the initial X-ray, we were able to see the glue cast as well as the stents. And a Doppler was done which showed patent main portal vein. However, there was attenuation of the intrahepatic IVC. There was mild proximal filling of the right hepatic vein, but there was no filling at all of the middle hepatic vein stent. The same findings were noted on the CT. We can see the glue and we can see the thrombosed stents. Now, after the clinical workup as well as the blood workup, diagnosis of JAK2V617F positive myeloproliferative neoplasm was made, which was suspected to be the cause of the acute Budd-Chiari syndrome. So the patient was found technically feasible for DEPS, however, was advised to wait till endothelialization of stents in view of the risk of migration of recently placed stents, which were placed 2 weeks ago. And she was also started on medical management and was asymptomatic for 9 months. She was kept on follow-up, but she presented again with abdominal swelling and lower limb after 9 months for 1 month despite being on optimal medical management. And a contrast enhanced MRI was done which showed cross ascites. The main portal vein was seen to be patent, but no flow was seen across the two right hepatic vein stent and the middle hepatic vein stent. So after an MDT, a decision was made to go ahead with a TIPS or a DIPS. So these are the interprocedure images. So we took an IVC venogram, we took the right hepatic vein venogram, the proximal right hepatic vein along the stent was filling. So what we did is we punctured the right hepatic vein stent, we plastied it, then we passed inside, punctured the portal vein, passed the glide wire into the SMV, and then we plastied the track. After plastering, we took a venogram, then we deployed the stent and we came out. The patient was kept on follow-up every 6 months, and this is a follow-up at 2 years. Now, just 1 month before the next scheduled follow-up date, she came with complaints of abdominal and lower limb swelling as well as abdominal pain for 2 weeks. Now, ultrasound was done which showed stenosis within the stent. So, we planned for a TIPS recanalization. Now, this was the initial IVC venogram. We tried both the wire catheter technique as well as the cannula assisted technique. So, we were not able to enter the stent. So, we decided that we'll go with a percutaneous transhepatic puncture. We took an 18G needle, directed cranially, punctured the covered part of the stent. Once we were inside, we passed the stiff glide wire inside into the right atrium. We snared it out of the jugular axis. We exchanged the jugular axis with a tip sheet, changed the wire to a stiff glide, took the cannula inside, and then we were able to plasty the stent. Post-plasty, there was some increase in flow. However, there is a rent in the covered part of the stent, so you need to put a new stent. So another pair of new stents were placed. For this patient's 2 tip stents were placed initially because the tract was long and you also had to cover a part of the right hepatic vein stent. And the percutaneous tract, the intrahepatic tract was embolized with glue. And these were the follow-ups at 1 week, 3 months, 6 months, 9 months, as well as 12 months, and all the follow-ups show good flow across the stent. Now, I'll show a companion case. This is a 31-year-old gentleman who presented with engorged abdominal veins for 8 months and abdominal distension for 3 months. On the review of outside CT imaging, a diagnosis of hepatic venous outflow obstruction was made, Budd-Chiari. So, we went ahead and we did a DIPS. The patient was asked to keep on follow-up, but as he was from a faraway place, he could not come back to us at 6 months. However, he came back 1 year later with massive hematemesis and acute ascites. On the initial ultrasound, we could see no flow across the stent, and there was also non-opacification, no blood flow within the right branch of portal vein, and attenuation of the left branch of portal vein. The CT confirmed the findings. There was stenosis within the stent, and also stenosis at the portal end of the stent and along the right portal vein. So again, we initially tried the wire catheter method as well as the cannula assisted method, but we are not able to enter the stent. Then we again took a USG guided transhepatic approach, took an 18G needle, took a step-guide wire, entered the stent, guided through the thrombosis into the right atrium, snared the wire through the IJV axis, changed for a tip sheath, tip cannula, and we plastied as well as stented the stent again. And this is a follow-up at 1 year, which again showed good flow across the stent. This is another companion case, a 36-year-old gentleman with abdominal distension for 6 months, bilateral lower limb swelling for 4 months, and jaundice for 1 month. Outside imaging showed no ossification of the hepatic veins and attenuation of the intrahepatic IVC with a patent portal vein. The diagnosis of Bacchiari was made, a dip stent was placed. The patient was advised to follow up, however, he was lost to follow up, but he presented after 4 years with abdominal distension for 20 days and leakage of fluid from an umbilical hernia he had. So we did an ultrasound, we could not find any flow through the stent. Then we again planned for a recanalization. We again initially tried the catheter cannula technique, the wire catheter technique as well as the cannula assisted technique. We were unable to. Then we planned a percutaneous technique. We accessed the stent using USG guidance through the needle. You can see the tip of the needle inside the stent. After we entered, we passed a step-guide wire inside and we crossed the stenosis and reached the right atrium. Then we changed it for a J-tip wire using a catheter. We snared the J-tip wire through the IJV axis outside. We changed the sheet to the tip sheet. We changed the glide wire to an stiff Amplax wire. Over the wire, we took the metallic cannula, took a glide wire and a catheter combination, and we negotiated through the stent into the superior mesenteric vein. Then we plastied and again stented, and this was the 1 year follow-up of the same patient, which showed good flow across the stent. So in-stent stenosis, the factors which contribute to the in-stent stenosis are technical factors like the shape of the stent or the length of the stent or the diameter of the stent we use, the physiological factors like intimal hyperplasia or the hemodynamics, and the disease or treatment-related factors like whether the patient is regularly taking the anticoagulants he's been given, or if in a case of cirrhotic liver disease, the cirrhosis, or in a case of Bacchiari syndrome, the prothrombotic state. The options for an endovascular management of in-stent stenosis include but are not limited to wire catheter cannulation, cannula-assisted cannulation, percutaneous transhepatic access, percutaneous transsphenic access, or an intraoperative transmesenteric access. At our center, we never required parallel tips. The percutaneous transhepatic recanalization was successful when the first wire catheter cannulation as well as the cannula-assisted cannulation failed in all the cases we did. And the take-home message from this presentation is routine follow-up is fundamental to optimal management of tips or dips, regardless of clinical presentation, whether the patient is symptomatic or asymptomatic. Thank you.